everyone. Welcome to Preemie Chats. Preemie Chats is a program for healthcare professionals and parents to talk about what matters most to you, to explore new ideas, and to learn together. I'm Leah Whitehead. I'm the proud mom of a preemie. I'm a former journalist, and I'm happy to be your host today from Halifax, Nova Scotia. Preemie Chats was created and is put on by the Canadian Premature Babies Foundation, also really well known as CPBF. The foundation is a parent-led charitable organization that helps families in and after NICU through education, support, and advocacy. If you have a heart for preemies, whether you're a family or a healthcare professional, please head over to their website, canadianpreemies.org, and there you will find resources, the latest projects, and most importantly, a community of people who want to see our little ones thrive. Today's session is live, so I invite you to please bring your voice to the table. It's always exciting to have people tell us where they're tuning in from, so let us know where you're from in the comments, and also forward any questions you may have in the chat session, and we'll try to address them today during our program. It is through rich conversations like the one we're going to have today where we can advance practice and learn together. So it's important that you bring your voice to the table today. On to today's topic. Lung immaturity at preterm birth compromises surfactant pools, gas exchanges, and airways. We can improve surfactant pools and gas exchanges with antenatal steroids. Bronchopulmonary dysplasia, or BPD as it's commonly known, presents long-term problems with the airways for which there is no treatment. The NICU graduates and their parents face problems of over-reactive and susceptible airways as long-term consequences of BPD. Consistent immunization and careful monitoring for other causes of airway reactivity, like asthma, are currently the only approach for long-term treatment. So our guest today is going to be looking at what exactly causes reduced lung capacity and how that interacts with long-term prognoses for NICU babies. I'm going to be joined here in just a moment by Professor Kramer. Dr. Boris Kramer is a neonatologist, leader of the experimental research group at Maastricht University Medical Center in the Netherlands since 2006, and professor for experimental perinatology since 2011. He's also clinical professor at the University of Western Australia since 2013, and in 2022 became chief medical officer at the Dutch medical biotechnology company Neuroblast BV. Welcome, Boris. Thank you for joining us here today.
Thank you very much for having me, and my apologies. Apparently, my CV is no longer up to date. Since 2 weeks' time, everything has been changed. I'm now a professor in Poznan University in Poland, so my apologies.
Oh, okay. Well, I'm going to put your presentation up here, and I'll let you get right to it because I know you have a lot of ground to cover.
Well, thank you very much. And especially, I want to discuss this with you and the audience. So if you have a question, if things are unclear, please do not hesitate to send Leah a question, and we have agreed that she may interrupt me at any given time. So the known, the unknown, and the challenges. What we know is that preterm birth puts every organ of a preterm baby into the situation to function in a foreign, non-natural environment. And if the lung cannot provide gas exchange, well, everything that the medical professionals will try is in vain. So the lung development is key to all these developments. And with ventilation, with oxygen, you cause injury. But the baby has, thank God, repair mechanisms, which involve stem cells, which involve modulation of the inflammatory response induced by injury. And these two forces are interacting and struggling, and the baby will either have lung problems, which we refer to as BPD, or will be normal. But what this normal actually means is a very good question. If you read the literature, you will come across old and new BPD. And I have put this together to show you not only the progress of the healthcare, but also that we are looking at completely different problems. So when in 1967, the term was coined, we were looking at 32 weekers of almost 2 kilograms. And they were ventilated, they got a lot of oxygen, and they showed some normal alveoli and fibrosis in other areas. And we have follow-up data of more than 40 years for those babies. Nowadays, we are looking at 26 weeks, 600 grams, and a completely different picture in the lung. We have a uniformly arrested development. And of course, the follow-up data in these babies is very different with respect to the time. I have shown, and I've taken an X-ray and a histologic picture to show you those differences. Here you have the fibrosis in red. This is like scar tissue. And here, no gas exchange is possible. Here you have normally developed alveoli, which are a very sophisticated structure. If you have such a little extension, you can do gas exchange from both sides. So you get an increase in the gas exchange area very easily. These fine structures are missing here. You have a very simplified lung, and the gas exchange in these big alveoli is not as effective as, for example, in those smaller ones, since here only from one side the gas exchange can happen. So that is one of the reasons why you need more oxygen. If you have a bottleneck in getting oxygen into the blood vessels of the body, then you have to have a higher gradient so that more oxygen can go through this little bottleneck and make sure that the baby gets enough oxygen. That is the definition, more or less, that we have been using for the past 50 years, that if there is a problem in gas exchange and more oxygen is needed, we call this BPD. Now, this picture shows you three-dimensional reconstructions of the developing lung. This is the situation that you expect in a term-born baby. You see here, almost like grapes, the small alveoli, and mind, this is increasing the gas exchange area exponentially. For example, you as an adult, take a deep breath now, and you have ventilated an area in your lungs which is equivalent to a tennis court. That gives you an idea how sophisticated this lung structure is and how efficient the space in your chest is being used by the microstructure to increase the gas exchange area. So in 1967, these babies were 32 weeks. This was the beginning of this phase of the lung development. Nowadays, we are looking at 26 weeks or even 22 weekers. And there we have the overlap between this lung developmental stage and this lung developmental stage. No alveoli, and the majority of the airway branchings have to happen. And in this situation, the baby is born and exposed to gas exchange. And if the gas exchange is not working in those immature structures, there is no possibility of survival. Antenatal steroids are the key how the baby can be prepared for this change. Here in the top left corner, you see a lung that is immature, and you see in red, these are the red blood cells which will carry the oxygen. And there are several layers of cells away from the air-containing structures. So you have a barrier of cells which will make the diffusion of oxygen into the body and carbon dioxide out of the body difficult. If you now give antenatal steroids for 48 hours, the lung looks like that. And these two experiments are at the same gestational age. Here you see no diffusion barrier anymore. you see that the red blood cell is really in absolute vicinity to the gas-containing structures. And that is the reason why antenatal steroids make a world of difference in these extremely preterm babies. This structure change is happening within 48 hours. Now you will ask, what are the lower two ones? This is the situation if there is an infection in the amniotic fluid, which is called chorioamnionitis. And this is the combination of chorioamnionitis and antenatal steroids. And you cannot distinguish these three phenotypes from each other. So irrespective whether you are giving glucocorticoids as antenatal steroids, which work against inflammation, if you have inflammation, or if you have inflammation and an anti-inflammatory drug, the lung will respond in the very same pattern. So you as parents of preterm babies have gone through the lung maturation and most likely also the surfactant therapy. Respiratory distress syndrome is not only the immaturity of the lung structure that we just have looked at, but also the lack of surfactant. And the antenatal steroids have a small effect on the surfactant pool. We can increase acutely the surfactant pool if we give exogenous surfactant. But what is really the vicious circle is that the alveoli, the lung structure collapses. The baby has to reopen these airways, and with the next breath, they collapse again. All this is injury to the cells that are covering these airways. And if cells are injured, they start to initiate an inflammation response. And part of that is the secretion of proteins. And albumin, which you probably have heard of, is the most potent inactivator of surfactant. So if you wait too long, this cascade is being kicked off, and then the surfactant is inactivated. So you have biochemically surfactant, however, albumin has bound those molecules and they are detectable, but they are no longer biologically active. And that is then the challenge to take a good decision when to give surfactant before you initiate this vicious circle. And that can be, in some babies, exclusively with antenatal steroids be inhibited or with the combination with surfactant therapy. So what is now happening with babies that go on and develop bronchopulmonary dysplasia? We understand what is happening on the alveolar level pretty good. You have focused depositions of elastin. If you are reminded now of the skin and that you should protect your skin against UV radiation, exactly. That is what we are talking of. This elastin is highly concentrated here in the developing lung, and it serves like a sign on the road. Into this direction, we want to grow an alveoli. And again, this is then accessible from both sides for gas exchange. And this marker is necessary for the neighboring cells to activate their programs of development and say, okay, we will now activate the program of an alveoli. And here you see the situation, a normally developed lung versus a BPD lung. You have large alveoli, but the overall area of this lung is way smaller than of this lung. And there you have then the problem with respect to gas exchange. I have put up some slides since I think it is very impressive to see in black the concentrated deposition of elastin in the healthy lung that is not being injured. And within 3 days of chorioamnionitis and inflammation in the amniotic fluid, you see that these concentrated depositions are gone. They are spread out also here after 7 days. And then the information is lost that the alveoli should grow into this direction. And if you have heard about vitamin A as an antioxidant, that is absolutely correct. However, the main function of vitamin A is a key to the gene program that is necessary to grow such an alveoli. And that vitamin A is so potent that the placenta seals off the fetus from vitamin A. And only in the very beginning of the alveolar phase of lung development, in the last third of the pregnancy, vitamin A is allowed into the fetus in order to activate this gene transcription for an alveoli. And you see here the differences in a schematic cartoon, and this is experimental data to show you how big the effect on the lung development is. Now, the long-term follow-up of those babies is depending on the countries. I think this is the politically correct term. And very few countries have a really consistent manner of collecting the data. The Scandinavian countries are those who can actually reach the highest percentage of its population. So all of a sudden it became clear that babies that are born preterm and have BPD have a different lung development in the long run. You have here these huge alveoli, cysts-like, that we have seen beforehand together with parts of the lung that are normally developed. So it does not grow out. Prematurity does not grow out. That is probably the biggest lie or the biggest mistake I have ever said about the prognosis of babies to parents. However, it is becoming clearer that not only the alveoli are affected, but also the airways. Here you see a lung of a 12-year-old boy, a former NICU graduate of 26 weeks and almost 600 grams with BPD. And here you see the age-matched control. And most interestingly, this baby, a young man, this former preterm baby, died of an asthma attack. The airways, exactly. So we have not talked about airways so far. We were completely focused on the gas exchange. So what is with the airways? We did a meta-analysis several years ago, and what you are probably seeing is asthma-like noises, wheezing disorders. And what we found is preterm birth is invariably of BPD associated with this kind of wheezing. If you are diagnosed with BPD, the wheezing gets worse. If you are born out of chorioamnionitis, it gets even worse. However, the background is there are problems with the airways. You remember that I put normal lung development after preterm birth in quotation marks? What is normal? And that is the very good question. Here you have now data from 2 Nordic countries, from Finland and Norway, and you see here the age going even up to 50. And you see here the rate of chronic obstructive pulmonary disease, COPD. This is a disease which is marked by a reduced gas exchange capacity and a kind of huge alveoli, which are then called emphysema. So very similar to the structure of preterm babies. And look at the incidences. It is amazing how high the incidence is, and that it is even in these children who are born several decades later not getting better. So our care is apparently not able to prevent these changes in airway reactivity. So when we prepared this session, I was asked about lung capacity. You usually reach your maximum lung capacity at the age of 21 to 25. And from there, everything is downhill with your body. And if you have exposure to toxic substances like smoke, the downhill gets steeper. And from a certain point of view of roughly 40% of the normal capacity, you have symptoms. You're short of breath, you need a supplemental oxygen. Now, the suspicion was that if a person cannot reach the normal level, then the slope goes down in the same inclination. However, if injuries come to it, you have the same rate of decline, but in the end, the symptoms will present at an earlier age than with a person who has a normal lung capacity. That was the assumption that there is no difference in aging and in the susceptibility to toxicity. Well, more recent data is now pointing to a different story. Former preterm babies are more susceptible to the bad effects of smoking than non-preterm babies. So the rate of decline is different. And this is true in the rates of responses to stimuli in the airways as well. So there is no growing out at all, and the decline in the function of the lung is faster. I showed you this nice 3D reconstruction of the different stages of the lung development, but I didn't point to the airways. I give you here some numbers to show you how fast the growth is, an exponential growth. So we are growing from 65,000 airways at 18 weeks up to 500 million when we reach term. Yes, a truly exponential growth. So now imagine if this is happening not in the womb, but with mechanical ventilation, high oxygen concentrations, inflammation going on, what a huge opportunity to affect growth by adverse events is there. And why are the airways so important? I show you here a cartoon, what happens with the flow of air if you have all of a sudden a bottleneck that is presenting. The pressure that is exerted onto the airways walls is changing. And of course, you have a different flow velocity. And all this taken together is a huge injurious stress onto the developing airways. Now, if you look at the development that should happen in utero with a low oxygen level, with a sufficient supply of all nutrients and a placenta that can act as a gatekeeper, especially with respect to vitamin A, then preterm birth is more or less a derailment of the development. And if you look at that, the immature lung structure, that will be then the result of this treatment. We have certain aspects that will be protective, like breast milk nutrition and postnatal steroids. And what we are trying is to help the repair mechanisms to get this back on track. However, what are the problems? Here you see the lung function at the age of 2 and the lung function at the age of 9 to 15. And each dot is one patient. So the very same patient was measured at the age of 2 at the age of 9 to 15. And 0 shows the normal aspect. The positive numbers are the better functions. The negative numbers are the lower functions. So if you are here, then you had a good lung function at 2, which then declined at older age. Thank God none of the patients was in that. Those had a good lung function, which stayed good. Those had a not normal function, but improved. But the majority had a poor lung function, which did not improve with age. So the window of opportunity to improve things is not very big, and it has to happen early in life. Since other data is showing into the very same direction, here we're looking up to the age of 22 years. If your lung function was poor, it stays poor. No catch-up growth. It will not grow out. No, it doesn't. So you have gone through that. The first 2 years, Some of you have taken oxygen back home. This is taking the intensive care unit back home. You have been motivated, warned about respiratory viruses. I have met a mother of a 17-year-old a teenager now who said, well, the motivation was pretty straightforward. The doctor said, if my baby gets RSV, it will die. There's nothing to do. Well, we have seen now a pandemic. Influenza is most likely the next one to cause a pandemic. Vaccinations, and situational awareness. Look at that tag. It reminds you of your golf bag? Yes, that is the use of a golf tag, and just making sure, wash your hands. No cold at my cot. And washing hands is one of the pillars that we have seen proven again in the last pandemic. So make sure that you help the parents to generate situational awareness. And when the proud, happy grandparents want to grab the grandchild, such a sign is very, very helpful. The school age asthma-like symptoms. Why do I write asthma-like symptoms? Well, preterm babies have per se wheezing disorders. And if you had complications like bronchopulmonary dysplasia, it is getting more common. However, this is not asthma. This is different from asthma. And again, the susceptibility to airway function infections, which mandates, again, the look after the immunization recommendations. Now, is there anything that can prevent this hyperreactivity? It is funny, one failed trial points to that direction. So 20 years ago, they had hoped that an enzyme which will be helpful against oxidative stress, the enzyme called superoxide dismutase, will reduce the risk of developing BPD. That was the primary outcome. Unfortunately, that did not do a difference. However, they carefully followed up these babies and showed no bronchial hyperreactivity in those babies treated with superoxide dismutase. So this is clinical information which has not been further pursued, however, points to a direction that the high concentrations of oxygens is a problem in those babies and in their development of BPD. So the high concentrations of oxygens, I show you here how the definition from 1967 has developed until recently. And you see it is getting more and more complicated. Does this help us? Yes, it helps us to better identify clinical conditions with respect to gas exchange, but it does not help us in any aspect with respect to the airway functions. So you get, even nowadays, special acronyms like the prematurity associated obstructive lung disease, the chronic obstructive lung disease of adult age. And I have put here the abbreviations on it so that you can understand what your reports actually say. The capacity of forced expiratory volume in 1 second is abbreviated like that. And if you take then the whole forced vital capacity over time, then you can make a ratio between those two, which gives you an idea how fast can you get rid of air. The lower limit of normal shows you a benchmarking, and it is, of course, the question, where does this value come from? If you are taking term babies, well, we have seen this as a completely different ball game with respect to lung development and risks. So these definitions try to show you, to describe what is the underlying problem. Well, the underlying problem is so obscure that the recommendations are suggesting. If a doctor suggests something, then you have to ask very carefully, what is the evidence? And the evidence is low, very low. Most of the treatments that we are trying to do in the NICUs are not really validated to the extent that we would say, yes, this is evidence-based medicine. One of the typical things are diuretics, which have never shown any effect on the incidence of BPD, which have shown a transient effect on the lung mechanics, but have never been evaluated for safety or other side effects. So, and if you go to one unit, you will hear one approach, and if you visit the next unit, also in the same city, the approach may be completely different. Now, for the first time in 20 years, a trial has been done, and it combined corticosteroids with beta-2 receptor agonists. And here you see the effect after the treatment with steroids alone, and here with the combination, and here the placebo treatment. So if you compare these effects, yes, there is a big effect. That is the best improvement we have seen in the past 20 years. And the authors are stating this very clearly, that that this is the first new evidence in the past 20 years that has been generated. And I have put this explicitly into the presentation, that the parents can ask their pediatricians or pediatric pulmonologists to ask the question, is my baby a patient that might benefit from that? If we put the bigger picture, we would like to prevent BPD. And in the definition of BPD, of oxygen need at 36 weeks, we are missing three populations. First of all, those who die before 36 weeks. The form of severe BPD is so sophisticated that we might not have all of them and the right approach. And the infants that die after 36 weeks of BPD. So we should know who these babies are and how numerous they are, because that is a population that has the worst outcome, and that might be the population that has the best chance of getting treatment. Getting treatment. If you now look at the trajectories that we looked at in the theoretical situation, the bad news is that apparently the aging of preterm babies is different from term-born babies. Do they age prematurely? That sounds contradictory. However, that is maybe the key to understand the underlying problems and to think of new treatment directions. And that aging is different has been shown in other diseases as well. So we have to revisit what is actually happening in utero and how this is being affected by preterm birth. Most surprisingly, a fetus has as little oxygen as if you are on the Mount Everest. So if the baby has so little oxygen, why is the baby then able to grow, which is the most sophisticated metabolic activity? And if you now look at the caloric needs, if you are doing the Tour de France, you are doing 100 kilocalories per kilogram per day. A preterm baby in our NICU needs 120 to 130 kilocalories. So something is different. If you now ask, are there cells that grow without a lot of oxygen, then the answer is yes, cancer cells. And that is called the Warburg effect after a physician who identified the preference of those cancer cells for glucose. Cancer cells crave glucose. And this is being exploited in one of the most sophisticated imaging technologies that we know, a positron emission tomography, CT. So you give radio-labeled glucose to the patient. The cancer has the preference for that glucose, so more of this radioactive signal is accumulating in the tumor, and you do a CT scan or an MRI to actually show where this location is. And that is the application of the basic observation that Warburg made. If you now feel reminded of chemistry and biology at high school, yes, that is true. So usually you take glucose, you put a phosphate group on it so that the glucose cannot leave the cell anymore. And then you are metabolizing this into a component called pyruvate. And that is a crossroad of metabolism. You can use that to make amino acids or other components that you need to make new proteins, new lipids, and to grow the cells. Or you send the pyruvate in a one-way direction into the respiratory chain, where then the molecule is in the end reduced to, is in the end oxidized to carbon dioxide with the help of the oxygen in the mitochondria. And this production of carbon dioxide in the mitochondria generates the general energy in the cell, which is called ATP. This is needed for the homeostasis, for the maintenance, for the operation of the cells. However, you do not grow out of ATP. You grow if you have the building blocks available, and they are made with the help of pyruvate. So a cancer cell is stopping its metabolism at this level. It wants to build metastases, the next generation of cells. So if you look now, where is this information about being a cancer cell kept? You can look at the cytoplasm or at the nucleus. This is a healthy cell, everything is green. This is a tumor cell, everything is red. So if you now take such a nucleus of a cancer cell and put it into a healthy cell, nothing is happening. But if you move the nucleus of a healthy cell into the cancer cell, the nucleus becomes a cancer nucleus. So the information is sitting here in the cytoplasm and has an effect on the nucleus where all the genetic information is kept. That is interesting. Why? The nucleus has the master program of development in it. And whether you are able to read genes or not read genes depends not on the DNA sequence, but on residues that are bound to DNA. And this either opens the DNA for reading and making proteins out of this, or it closes it and it is not available for reading. And this is, of course, very important at the beginning of development in the embryo status, but also throughout the whole pregnancy. Now, this is called epigenetics, on the genes added information. And that is something that shapes your life. For example, there is the Dutch hunger winter. When the Allies freed the Netherlands, the Nazis reduced the calories as a retaliation from 2,000 kilocalories to 400. That is a severe starvation. The Netherlands has followed up those children over decades, and with the moment of this famine, their programming for diabetic susceptibility, for high blood pressure, changed completely. And that is an effect of these epigenetic changes, which the mother is then transmitting to the fetus in order to prepare the fetus for the environment it will encounter. What does this mean? It means that we have understood that pyruvate is the interesting component for both the cancer cell and for the fetus who wants also to generate the next generation of cells. But these enzymes are also present in the nucleus, where the metabolism provides then these informations on top of the DNA, which opens the DNA for development. This alpha-ketoglutarate is important for development, especially for stem cells. Now, what happens if the fetus is no longer in its environment? When all of a sudden 21% oxygen is the minimum. 21% oxygen is a flush of oxygen in comparison to the Mount Everest. What can you do with oxygen if your enzymes are not there to detoxify it? You can metabolize it. You can burn it to carbon dioxide in the mitochondria, which means that you open this metabolic pathway in order to get rid of the oxygen that is sitting there. So that is happening after preterm birth, and that puts a completely new focus on the questions how we should try to get the development back on track. It is not getting easier, surely not. Any idea that we have a magic bullet turns out to be wrong because we underestimate the complexity of the biology. However, if we pursue these questions, whether the metabolism is changing the developmental pattern, then we can ask new questions how to approach preterm birth as such. So take home messages. I usually give take to work messages when I talk to medical professionals and advise them to keep their professional life and their private life separated. Well, you as parents of preterm babies, you have our work situation at home. So prevention of further damage. And the key to that is immunization and no exposure to tobacco smoke. And not surprisingly, passive smoking is also injurious. So please avoid the exposure to tobacco. And in the Western world, this is getting more and more general acceptance. For example, a baby does not have to be transported in a private car where the parents smoke. That is something where you can make a difference. The idea is how we can actually improve the airways is critical. We do not have good biomarkers for that at early ages. There is something that we usually completely ignore in the NICUs, that is sleep. And the parents will have a hard time to adjust to the sleeping patterns of their preterm baby. Pulmonary hypertension is the blood pressure being too high in the blood vessels going from the right heart to the lungs. That is very difficult to treat, but it is very common in babies with BPD. So this is something that has to be checked and then treated separately. So the microbiome is also present in the lower airways. That is something that we start to understand, but have no actual grip on it in order to improve the outcome. However, inflammation may be the result of changes in there that has then adverse outcomes and adverse effects. The re-evaluation of treatment in the long term is now, thank God, a priority in the research agenda. And in order to improve the long-term outcome, I'm afraid we have to revisit very basic mechanisms of growth and development and to understand them better. So thank you very much for your attention. I'm very much looking forward to your questions, and thank you.
Thank you very much for that presentation. We have had lots of questions and comments that have come through, so I'll get right to them. We'll start with one from Jay, who said, one of the questions I have is it normal or expected to be considered or diagnosed as BPD if a preemie baby has been on CPAP for at least 2 months, even though all scans show negative?
Jay, thank you very much. Which scans do you mean as negative? X-rays? I don't know. We have understood now that mechanical ventilation is bad for the lung, given all the susceptibility against mechanical stress and shear stress and oxygen toxicity. So our aim is to reduced either to prevent mechanical ventilation or to reduce it to a minimum of time. CPAP is therefore the first alternative that you consider. However, the longer you give it, the more side effects you have. So CPAP for a long period of time, like 2 months, is of course a risk factor to be considered. However, the most important risk factor for BPD is gestational age. And therefore, if you could provide us this information, we can then put the answer into the right frame, and also which scans you mean. If you refer to X-rays, they are not indicative of BPD.
Jay did clarify and said ABDO or ABDO and CXR scans.
CXR, these are chest X-rays. Yes, they cannot exclude BPD.
And born at 27 weeks is that other detail.
Yeah, so that is still in the high risk group for BPD, but not absolutely, more or less predictive. If you look at 22 weekers, they all have BPD in the definition of oxygen needs at 36 weeks.
We have a comment that I'm going to put up here from Ashley. She was born at 24 weeks and she's now 40. She said she has chronic lung disease. I do not currently have a specific diagnosis, but recent X-ray and CT scans have said either emphysema or COPD with lung scarring. I also have PFTs showing a trend towards restriction.
Ashley, thank you very much. May I ask you a question out of curiosity? Has your pulmonologist asked you whether you were born prematurely? That is something that the adult doctors are not taking into account. Preterm birth affects roughly 10% of the whole population. They ask in standard manners, even rarer diseases. However, the question after preterm birth, how long the gestation of your pregnancy lasted, is usually missed. So what you have is this POLD, and you should use the question when you visit your pulmonologist again, that you are most likely in this diagnostic category, and that he or she should look for clinical trials that are being conducted, because that is exactly the population where we do not know what to do best. And if you are following this chat, this might be an opportunity to ask to be enrolled in a clinical trial.
And Juliet had a similar comment. Juliet said she's from the Netherlands. She is a preterm born adult. She was born at 28 and a half weeks in 1980, living with BPD. And she says, I was re-diagnosed again with BPD in 2020. I was first diagnosed with severe BPD as a baby, misdiagnosed with difficult to treat asthma from 2006 to 2020, and re-diagnosed again with BPD in 2020. Asthma was completely excluded. BPD looks very similar on CT lung scan, just like emphysema, COPD, and can also have scarring.
Absolutely a typical case. This airway reactivity is, if I may say, misinterpreted as asthma, but is underlying associated with being born premature. So that's something you have to always put forward when you talk to adult doctors. I was born preterm. And if you are having respiratory symptoms, then ask the questions, are we looking at airway reactivity or truly asthma? Of course, there are some former preterm babies that have asthma, but it is the exception of the rule, not the rule itself. And yes, COPD and this emphysema is used in parallel. And yes, exactly, this is the lung structure which you probably had all your life and which is now revisited and is, due to your age, then labeled as COPD. However, this is the result of your preterm birth.
Jay had another question. Once a baby is considered BPD, how much steroids could they give? Is this up to a certain gestation, or is this going to be a long-term therapy?
My goodness, I was afraid of that question. No, she got me. No, she got me. In every medical treatment, we have just to answer 5 simple questions. Which patient should be given which drug, at which dose, via which route, at what time? And despite using postnatal steroids for more than 6 decades, we cannot answer these questions. So postnatal steroids have side effects. And we have seen only around the 2000s that they are neurotoxic, meaning they are bad for the brain development. Therefore, the indication for postnatal steroids has to be absolutely strict. So you have to make sure that you have tried everything else, that you are giving the right drug in the lowest possible dose for the shortest period of time. And that is a tricky decision that the team has to take. And in the perfect world, you as parents are involved in shared decision making. And you will be very sobered up about doctors who tell you, we do not know what is best.
Juliet had another comment. It got cut off, so I'll read the tail end on a different screen here. But she said, did you know the following? The Netherlands has an expertise center in Erasmus MC, outpatient clinic, congenital and perinatal lung diseases with pulmonologists. First outpatient clinic in the world for preterm born adults with chronic lung diseases. Around 500 preterm born adults are visiting this expertise center. Also, preterm born adults from outside the Netherlands are visiting the center to receive a proper diagnosis and treatment plan and advice.
Yes, Juliet, this is based on a patient center that Miel Wouters developed in the area of Maastricht, a one-stop shop where you as an adult COPD patient come to and you are analyzed for metabolic, cardiovascular, and of course pulmonary effects. This was the basis or the blueprint for that center, which is now focused on patients younger than the typical COPD patient. So yes, that is the way how it should be done, and that all the expertise is lined up around the parents and their child, and not that the parents have to go from one outpatient service to the other one.
Now, we talked about this just briefly before you started, about my daughter. She was born at 28 weeks. I had choreo when she was born, and she is now 10, and she is given a lung function test twice a year, which she does not do well on. And so she's on a daily puffer. However, she doesn't have any other asthma symptoms. So whenever they do the test, they always say, oh, your daughter must have a hard time keeping up with the people in her gym class. And I'm like, no, this kid is super active. She plays basketball. During COVID, when I was running, she was biking along beside me 10 kilometers a day. She's very active kid, and yet she still does miserably on the lung function tests and is diagnosed with asthma. And so I wondered if I could get your take on that.
What is in the puffer?
Good question. And I should know that. It's a mix of a steroid and a long-term something.
Mimetics. Good. Yeah. Well, is the pulmonologist team aware that your daughter is in a former preterm?
Yes.
Have you asked them the question whether this test result may be the result of being preterm and not the result of asthma?
So I have asked that, and the question that I get back is always, yeah, probably, but because this is how it's presenting, we're going to treat it like asthma.
You can do a very ultimate approach and stop the medication and see what this is doing. because if it is not asthma, well, then asthma medication does not work. However, the clinical trial that I showed you about these corticosteroids and the beta 2, that is the current level of evidence. So make sure that this puffer is this level of evidence, and if you still have doubts, then reduce it and see whether this is changing or not. And the other aspect is, if our clinical symptoms and the measurements would go hand in hand, we would have made much more progress.
And when you say B2 or beta 2, is that in the form of an inhaler as well?
Yes.
Okay.
Yes.
I'm writing that down. So I have questions.
Sure.
I love that you're giving us all practical tools on almost how to advocate for ourselves in the doctor's office.
And this remark about this expertise center is a great one. Usually, you are looking for the right doctor, so you are shopping with the doctors, and yes, it is usually the common approach that you have to really look for the right doctor for your problems. If you have a higher chance to meet this doctor in such an expertise center, yes, that's a good approach. The Netherlands are 17 million people and 350 kilometers in the maximum diameter. For Canadian habits, that is a different ballgame. So you have to see whether the center of expertise is the best approach for your country. However, the concentration of expertise in one center is, of course, always better than the dilution over the area.
There's just one more comment that I'm going to put up here again from Jay, giving you a run for your money today. Dr. Kramer, that is an interesting point about Lasix. It makes me wonder how some neonatologists consider this as a main treatment for our NICU babies who have BPD.
If she passes this on, my neonatal colleagues will be angry with me. No, the point is, we are striving for evidence-based medicine.
Yes.
And evidence-based medicine is generated out of randomized, placebo-controlled, double-blinded trials. Lasix has never had such a clinical trial. Lasix has been shown to change the mechanics and to reduce the oxygen temporarily. If this has any effect on the severity or the incidence of BPD has never been studied. If we would be diagnosed with hypertension, one of the main drugs would be diuretics to reduce the blood pressure. Has this been studied, whether this has an effect in our preterm babies? No. What is for sure is that sodium is being excreted by the urine. So water goes with sodium. So if you want to get rid of water, you have to get rid of sodium. So if you give Lasix long enough, you will reduce the sodium concentration to levels which can be dangerous. Every low sodium level is not helpful for the neurodevelopmental prognosis. So the discussions when to give Lasix, how long to give Lasix are usually the key components where you see how different evidence is differently perceived by the doctors. And yes, we have then agreed in the team in the long run that we make a test whether the oxygen is being reduced, that we monitor the sodium, and that we reduce the administration period to 1 week and then to reevaluate the situation, since the evidence is so low and actually non-existent.
It's very interesting, and I love that you're posing lots of questions and really getting all of our viewers thinking, I'm sure, based on the comments and the questions that are coming through. So thank you so much for joining us today and for sharing your expertise with us.
Thank you very much. I wish all the best. And yes, you are the pioneers in this. And please join every clinical trial that is applicable to your child or to you as an adult. Without these clinical trials, we won't make any progress. And your treatment has partially been built on the willingness of others to participate in clinical trials. So please join the trials.
Good advice for all of us. Thank you. And thanks again for joining us.
My pleasure. Thank you very much for having me.
And thank you, everyone, for joining us today. That was awesome discussion, information. And I always love it when we're provided with tools as families and healthcare providers that we can, again, expand our thinking on certain areas of prematurity. This special edition of Preemie Chats is sponsored by AstraZeneca, with the collaboration of the Canadian Association of Neonatal Nurses and Family Integrated Care. Just a reminder that if you have missed part of today's session, then you can head over to canadianpreemies.org, our website, to see this episode and all past episodes as well. While you're there, you'll also be reminded that Canadian Premature Babies Foundation is a charitable organization, and it depends on support to continue its work. If this is the time of year that you give gifts, then I just invite you to consider whether you could give a donation in a special person's name, and then you can also support CPBF in its mission to empower families of premature babies in every step of their journey. Together, we can create a brighter future for all preemies and their families. I put it on the bottom of the screen there, but just wanted to remind you that Preemie Chats will not be here next Friday. In fact, Preemie Chats is taking a brief pause until January 19th. We hope that if you are celebrating a holiday this December or January, that you have a happy and restful one. Stay safe, and we'll see you back here in 2024.